So, who am I? I'm a retired GP. I was a teacher, a trainer, a lecturer, and now, and for quite a time before I retired, I'm an accredited GP running a low-risk skin cancer clinic. In other words, I'm treating basal cell cancers. So what am I doing here in a melanoma conference when I don't treat melanomas? So I'm going to basically say, in our first panel discussion, it becomes quite obvious that there are big problems for melanoma patients. There are big problems for melanoma patients at the GP interface and at the hospital interface. So my role is providing someone who actually knows what things look like and knows how the dermatology system works, and a quick referral for those I can recognise. And my role is also, by treating the low-risk cancers, I remove from that 2-week wait clinic that is grossly overrun a large proportion of their patients. And round here, we have 4 of us, 3 clinics, running low-risk cancer clinics, and we treat nearly 15% of all the low-risk cancers, the ones that don't really need to take the time away from serious cancers. So, GPs. Who are we? There are about 33,000 of us in England. That's about 1 per 2,000 people. That is grossly less than in any other European country. But 98% of all people in the UK have a GP, or rather nowadays don't have a GP, they have a GP practice. I know the government keeps telling you that numbers are higher than they ever have been before, but as of last November, they haven't. There are fewer GPs trained than there ever have been before per patient. Yes, there are more numbers, but there are an awful lot more patients. And of course, the strain of all what is going on has meant that GPs are voting with their feet and they are working fewer hours. Traditionally, we've been meant to see patients every 10 minutes. Actually, when I started, that was considered generous, and the average was 6 minutes per consultation. That is not long enough. But despite that, it's often difficult, nay, possibly impossible for patients to get an appointment. My own practice takes access very seriously, and it is always possible not only to get an appointment to see a GP the same day, but to see the GP you choose within a couple of weeks. That takes an enormous amount of work. Other GP colleagues don't understand how we have managed it. And since I retired 5 years ago, I'm afraid the situation, even in my own practice, has deteriorated. So, GPs and cancer. In England, nearly all patients with cancer either get missed completely and turn up an A&E, and there's an embarrassingly large number of people who do that, or get referred by their GP. The NICE guidelines latest upgrade in 2015, suggests that we refer them by this 2-week wait system. It's a very confusing name, the 2 weeks, which is meant to be the time between you see your GP and you first see a hospital consultant, is not what the system is designed to deliver. It's designed to deliver treatment within 3 months. I think that is because the very worst cancers, cells divide about once every 3 months. In the latest guidance, NICE has suggested that GPs refer if there's a 3% chance of something being cancerous. That has meant that, let's take the dermatology situation, it has meant that less than 1 in 10 of all the patients sent to the cancer clinic have any form of cancer at all. It has overloaded the system, and in this neck of the woods, the dermatologists have been unable to see 2-week wait referrals within 2-week waits, 2 week for the last 2 months. They have sorted things out, and by the end of this month, they are predicted to have got back on track. There are very detailed checklists of what we should refer. And if we followed the checklists, we would miss a large proportion of melanomas. No, I've gone back, sorry. So, as GPs, we're not just seeing melanomas, we're seeing all the cancers in the world. So, melanoma in England, and I use English things because I couldn't get UK-wide standardised figures, and the latest I could get were 2016, which were from Cancer Research. There were just under 14,000 new cases a year. That is 1 in 20 of all cancer diagnoses per year. It killed just under 3,000 people, which is 1% of all cancer deaths. And greatly to all of your surprise, the peak age of diagnosis for melanoma is in your 80s, and the peak age of death is in your 90s. And I'm thinking, I can't see many people who look as if they're 80 in this audience, and certainly nobody who looks as if they might be 90. So in general practice, patients in general are worried about melanoma. Whether or not they have it, they're worried about it. GPs are worried. A large practice, like mine, with 15,000 patients, will have between 3 and 4 new cases a year, and we will have referred 40 patients to the hospital with a suspected melanoma. And every single one of the patients and the GPs will be terrified. But why? Why all the fear? And the fear is because melanoma is very curable. 90% of people at the moment are completely cured of it. But melanoma can kill quite young people, and the internet is full of their stories. And melanoma is not easy to diagnose. Even dermatologists with a dermatoscope can get it wrong. Oops, sorry. Two pictures. Another picture. Decreasing the fear If we get better at making safe diagnoses of at-risk lesions, this decreases anxiety all round. And I'm an ambassador for skin, and we've just launched an online interactive educational programme aimed at educating GPs, nurses, and everybody in the health thing about this. This is called Masked Pro, and it's been launched about a month ago. It's for GP trainees, it's for GPs, it's for other health professionals as well. It's very good. I would say so. I helped to develop it. So, with better education, in theory, we should have fewer of those awful things. My GP missed it. My consultant missed it. My histology was wrong. I don't know. For most melanoma patients, their GP is not part of their regular treatment. But they do have an important role to play. We continue to look after you after your diagnosis. And although your nurse key worker and your consultants will be controlling your treatment for melanoma, you may get flu. You may get other things. We have a more important role for those who are, in inverted commas, cured. Discharged from hospital care after 5 years, off you go, we've sorted you out. One of my roles is providing rapid, patient-initiated follow-up for these patients, because that's what's needed, and hospitals seem to be unable to provide this. The commonest cause of death in somebody who has had a grade 1 cancer completely cured is, grade 1 melanoma cured is a different melanoma. So we do need to be alert. And of course, GPs come into their own when you're not cured and you fall off the far right end of the patient pathway that you saw and need palliative care. Some frequently asked questions. Why don't GPs just remove all suspicious moles? And although there is evidence that this actually is a safe approach, we have strict guidelines that say that we must not do it. And a GP who does get sent a nasty letter from the powers that be, and people who do it regularly get banned from doing all surgery. So bear with us. And why didn't you refer me 5 years ago? And we can't get it right all the time. Of the moles that look okay, some of them we got it wrong, and 5 years later they aren't okay. Only a minority of melanomas, about a third, arise in existing moles. So my practice's approach is that any GP who sees something that they're suspicious it's melanoma and it fits the criteria gets referred. And then I run a fortnightly clinic where I see anything that they're not sure about and they just want a little second opinion quick. And I see them, therefore, within 2 weeks because nobody doesn't get seen the next clinic. And over the last year, I've referred 10 patients via the 2-week wait, and 6 were for suspected melanoma. And most of those, 4 of them, were referred by colleagues who'd seen something that didn't look like the classic picture of a melanoma, but I thought it was. So now, some more pictures. And I'm going to say, you've seen 5 pictures. 3 of them were melanomas. Do you know which ones? Because I'll tell you, I don't.